Correct.
Does it shift because the bone shifts with the tooth?
Yes. What makes the bone shift? That's the thing. Question.
Mm, not sure.
So in the bone, there's multiple cells. There's osteoblast. Osteoblast that's great bone. That's great bone. It will secrete the matrix and goes back and retreat, and the matrix will ossify. The matrix is mostly it's fibers and protein, and then the calcium and phosphate comes from the interstitial tissue and create a bone. So whenever there's a pressure uh, or less pressure, there will be activation of osteoblast. Osteoblast will create bone. If there is pressure on the other side, that we move the if you have central incisor forward, you push it backward. Too much pressure will activate another cell called osteoclast. Osteoclast is a multicellular big cell, a big large cell that will eat the bone. So if you when you push this, you push the central incisor backward, osteoclasts will eat the palatal part, and osteoblasts create bone on the buccal side. That's the physiology of the growth in general. The bone continue grows, or they grow and remodels and remodel. So sometimes osteoclasts, I've seen it with patients when they wear braces for more than 3 years. Osteoclasts get crazy, eat the bone and eat the roots. The root it's been eating, like, and the tooth when you remove it is like baby tooth. There's no root because there's too much pressure for many years. It will activate the osteoclast, and there will be no roots at all. And that's another bone resorption, root resorption, and one of the cause of you lose your teeth.
What causes
And
what causes certain devices to be rejected by the bone? Because I've had dental work done where I had TADs put in
implant
my gum and they were rejected. What makes the bone force that out?
incompatibility, infection uh, is not. Sometimes they use the wrong. Uh, it failed. Osseointegration when there's real attachment. Maybe I'll give you a story about how they discover implant. Implant. There's a guy. He's orthopedics. He do fracture bones, and he's not a dentist. He did the titanium plates on the rabbit uh, legs, and after 6 months, he tried to remove the plate. He couldn't. The plate fused to the bone. So he said that's osseointegration. Somebody else coined that first phrase called osseointegration. So that why can I do teeth? They start doing that osseointegration. They put titanium plates inside the bone, and they start with dogs. There's a picture of a dog suspended by his teeth. Yes, it's very, very, but they did that. Start with the dogs. Then for 20 years they start osseointegration, and they did many implants. That's in Switzerland. And after in 1980s, there was a conference in Canada, and then American dentists discovered that. Before that, they didn't do intraosseous implant. They do subperiosteal and transosseous. Transosseous will grow like if you cut incision here, and you drill all the way to the end, and you put the plate connecting the implants. They're called transosseous. It's a big surgery. Not every dentist can do it. You need an oral maxillofacial surgeon to do it. But then they got that. Nobel Biocare, Nobel Biocare. He made that brain marks. He made that thing. Nobel Biocare is one of the biggest implant companies. BioHorizon, uh, one of these things. So these are the implant they started using. I guess. Anyway, let's talk about complete denture because I didn't see anybody here. So complete denture is a bread and butter for dental lab technician. Even with implants, either with digital dentistry, you have to know complete denture. You have to make complete denture. Complete denture is the most common Most common missing teeth is a complete denture. So if you there's this saying of my teacher that said partial denture is always temporary before complete denture. Because if you lose multiple teeth and need a partial denture, eventually you'll and have complete denture. Especially if you do acrylic partial denture. Acrylic partial denture is just temporary. Uh, the problem with when you lose all the teeth, you lose retention, you lose the stability, you lose support. And with time, you lose all that. So, and what's the chief complaint of people when they lose all their teeth? What they want? I don't think aesthetic because it's aesthetic because they will immediately they lose the center and size, they will go. It's not aesthetic. It's a function. They want to eat. And most of people they wait until they will have their certain age, they will have Medicare, or they move to the other area and they have Medicaid.
Mm-hmm.
And in North Carolina, they expand Medicaid 2 years ago. Did you hear about that?
Mm-hmm.
They expand Medicaid 2 years ago in North Carolina, and there was a flood of people need complete denture because they couldn't afford it, especially Western North Carolina and Southeast North Carolina. You can see people without teeth, and so what happened when the expand Medicaid paid for a for complete denture every 10 years. Every 10 years, I have a patient. She lost her denture. She went to the police, get a report that she lost her complete denture, so she can send it to the insurance company so they can pay for her denture because
Oh, wow.
they don't pay for a denture until 10 years, or depends on the which insurance. Medicaid don't pay for it, and Medicare does, but Medicare does with Medicaid, and Medicare and by itself doesn't do dental. You have to combine Medicaid with Medicare with Medicaid. So Medicaid is a big deal, and then in the prison program they have a big lab, and most of the dentists they do extraction, denture. They don't do nothing. They do cleaning sometimes, but you see the the flood of dentures and stuff. Anyway, so the complete denture is a big deal, and most of dental lab technician you have to learn how to do it. There's the patient when they lose their teeth, they lose many things. They lose the vertical dimension. This is vertical dimension. When you close your teeth, you not close your teeth more than normal. That's it. You cannot close your teeth, close your jaws more than that. Uh, when you lose your teeth, you lose that vertical dimension. There, you lose the horizontal dimension. And horizontal dimension in dentistry we call a centric relation. You know what centric relation? When you buy it, you have teeth. Your teeth will guide you. You buy it like that. So you're not gonna buy it forward or backward. That's centric relation. And when we try to create a denture, we have to create a denture on that occlusion pattern, which is centric relation. Why the centric relation? Because the muscle, the ligament that suspend the mandible, suspend the face, all of them, they maximum force and the stability on the centric relation. That centric relation, when you bite like this, that's when the teeth. So if you have a patient has all the dentures, all partial denture, all cast, it's very grateful, useful because we have their own centric relation. Otherwise, we have to record that relation, centric relation. Sometimes centric relation is not only horizontal because it's combination of muscle movement, ligament. Uh, that's why dental lab technicians they should know about the anatomy, the muscle of mastication, the ligament that move, the joint, the uh, the movement. Even we have muscle of mastication. There are four muscle of mastication. Remember them? Masseter, temporalis, medial and lateral pterygoids. There's another extra. There's another extra muscles. We call it the suprahyoid muscles. Do you know these suprahyoid muscles here from the hyoid? They attach to the hyoid bone, and when they activate, they pull the mandible downward too. So these muscles have also we should know about them. Other thing, there's an anatomical challenge when we do a complete denture. A complete denture, the denture acts like a unit, one unit. So if one tooth is higher than the other, the denture will lose stability. While if you have multiple teeth, if you have natural teeth, if there's one tooth has a problem, you can chew the other side, you can grind that tooth, but the denture will act as one unit. That's another thing. Let me share. I swear I should send them, and I have just one email from Cody. He said he couldn't make it. Cody's working, and can you see this?
Yes.
Yeah, that's the complete denture component fabrication process. Complete denture as a dental lab technician. Complete denture is removable, of course, but nowadays we can do implant and make the denture. We can do it fixed and we can do it over denture. Do you know what's over denture?
Is that where it snaps into
Yeah, it
the?
snaps on either ball or socket of implant, or you can do the canine. You know, the lower canine, they are the strongest teeth in the lower jaw. Also, they have long roots, and they rarely have decay. So sometimes they lose the central incisors and premolars, but the canine is still there. So we can do root canal on these canines and make them like a ball and cover them with a crown with special shape, or we can put a bar between them and make the denture snap on them. We call it over denture. But nowadays with implant, we can do more. We can do implant, and the implant will seat and cover the denture. And there's a locator. I have a lecture about locators. Locators, they are plastic cups they put on the implant. Some of them, they are very strong. They can be fixed, cannot be removed by the patient, can be removed only by the dentist. So you create a fix when you do fixed complete denture, you have to remove the flange of the complete denture. Why?
So the plastic caps, you said they still go over the canines?
No, if you have implant and we make the implant fused on the implants there, and the denture either fused to this implant through screws or through locator, it fixed. Usually, the dentist has to remove the flanges that move in the vestibule. They remove them because of hygiene. You have to clean. You have hygienic part because you have to clean it. And I keep telling my colleagues that they make dentures. You can give the patient a gift, a water floss, because they never clean it. The water floss, because they spend a lot of money on these implants, and if they don't brush under their bridge or under their denture, they will lose them sooner or later. Because no one, they don't care. They already lost their natural teeth, and they have to. So you can do water floss or threaded floss because these are fixed. In regular or traditional complete denture, it sits on the tissue. The more tissue you have, more support. That's why we always have a problem with the lower denture than the upper denture. Lower denture because there is no space because of the tongue. Upper denture, we have the palate, and we have more stability and more suction. Suction act like a retention, and also muscular retention. There's a video I'll show you. There is a soccer match, and a patient with complete denture, he used his denture to clap with his tongue. It's amazing because he has the neuromuscular control of that. And the patient has the dentures a fracture, but he kept it there because the muscle he controlled it. And most of them they lost their teeth early when they are young, so they live all their life with dentures. So their muscle, tongue, the cheek, the lips control the stability of the denture. That's why a dental lab technician should know about the muscle of the tongue, muscle of the cheek, muscle of the lips, how it works, and why we do the good impression. And one of my teachers said, good impression will be a good denture. If you have a good impression, you will have a good denture. And if you don't have a good impression, you will never have a good denture. That's so why we make a denture? We need function. Most people they cannot eat, they are soup. Uh, I uh, did you see my YouTube videos?
With the
Uh,
guy getting fitted.
yeah, I made there's a song about toothsmith. You should, yeah, I'll send it to you about how it's important toothsmiths. They call it toothsmiths. They create the tooth and how they are important. Anyway, so they I'll send it to you. So we need to replace the function, which is most important. They cannot chew and digest food, and we restore the aesthetic, phonetics, and speech. That's important too. Um, Most complete denture you do by we use acrylic, but nowadays there's zirconia. We can use zirconia. Sometime in the college where people with a master's degree they use metal plate on the especially in the upper denture. We can use a metal plate. The metal plate they think will make it lighter, but the other thing, the denture teeth, they made of acrylic, so retention will be different. Some people sometimes they use a ceramic teeth and to be in the denture, but when you have a ceramic teeth and acrylic denture base, the ceramic teeth has either wire or a hole, so the denture base will go inside to make retention. Um, and no one uses porcelain teeth here, as I've seen it all acrylic. There's a steps. There's a big lecture about step of complete denture. I'll summarize it. So first steps, the patient comes to the dentist. The dentist will take history, discuss the payment, insurance, and everything. And if everything okay, they start taking impression. Usually, if you have one impression, it will be great. But the problem is every patient differ from the other because they might lost their back teeth before the anterior teeth. They lost the molar before the central. So they have irregular alveolar bone, and we call it residual ridge. After we extract the teeth, the remaining bone we call residual ridge. And when we take impression, usually we use stock trays. Stock trays comes in three sizes: medium, large, and small. So these will take impression. Although we have very good impression materials, most of the dentists they require another one. So we create a special tray. They take the primary impression, send it to you. You made the stone, you make it of steady cast, and on the steady cast you create what are you going to create on the steady cast? Call it special tray or custom tray with the handle. Remember that? You made that custom tray? No. The custom tray we made it on the. We can make it. We will make it on the steady cast, and then on the steady cast we'll create a special tray, record a special tray or custom tray, and send it back to the dentist. Now the dentist will take good impression because this have at least the dimension of the patient. You don't have to write it. I'll send it to you.
Taking mental notes.
Yeah, it will help. When you write it will help. So this is a special tray. Send it back to the dentist. and they will take final impression. Now the final impression will be much better than primary impression or first impression. On the they take final impression, send it back to you, and because the patient lost their teeth long time ago, they lost the support, vertical dimension, horizontal dimension, and we need to measure all these. So we have to create a device. It's made of acrylic. We call it record base or bite block. It's made of wax and acrylic, and it has a wax bite, and the dentist will put it on the patient and see the support for the lip. If there's no support for the lip, they add wax. If there's too much, they remove wax. And they see the vertical dimension. They see they measure vertical dimension, which is the normal. If they have a previous cast or previous picture, they can use it as a reference. Sometimes there's a one way we can get the vertical dimension. We call it vertical dimension of occlusion. When you bite, vertical dimension of occlusion. And there's vertical dimension of rest. When you sit upward and you're watching TV, the teeth are not in touch. They call vertical dimension of rest vertical dimension. And the vertical dimension of rest is about 2 to 3 millimeter longer than vertical dimension of occlusion when you bite. Imagine yourself when you like sit like this and the teeth not connect, just relax. That's when the muscle relax. And there's suspended ligament. There are 3 ligaments, one in the TMJ, there's ligament on the stylomandibular ligament, and the pterygomandibular ligament also, and there's ligament around the TMJ, temporomandibular joint. These are suspended, and also the muscles, when they relax, also act as a suspender for the mandible. So when they are relaxed, the mandible most relaxed position, that's called rest. So the dentist can measure that and reduce the amount by 2 to 3 millimeter. We will find vertical dimension of occlusion. There's many ways we can do it to make them. There's one way is because the maximum pressure can do with the natural vertical dimension of occlusion. There's electronic measuring for see the bite, whereas the maximum bite we can find the maximum bite, which is the one when we have the vertical dimension of occlusion, but this is more expensive and more in lab or colleges. So the dentist will find vertical dimension, horizontal relation. He will find the midline. Most of the dental lab, they work away from the dentist, but if you work with the dentist, sometimes you have to do like Aspen Dental and some other tooth in a day, they have a dental lab technician with them. So sometimes you work with the dentist in the clinic and they will find the midline. Midline is very important. They find the canine line. Where's the canine? Usually the canine line is where the nose here or the pupil are. You find the canine line. Why the canine line important? Is the transition between anterior teeth to posterior teeth when the arch started. So the canine line should find it. Other important line is the smiling line. When you smile, you should show 2/3 of the 1/3 of the central incisor. So you have to find the smiling line. So all these lines, the dentists mark them and send it back to you. On this line, you set up your teeth. In the midline, you set up your teeth, and when you reach the canine, you set up the teeth.
So
all these measure.
So does this all happen after the special tray is sent back? All
Yes.
these measurements?
Yes, these. Okay. The first step, the dentist take first impression, send it back to you. On the first impression, you make a steady cast. On the steady cast, you make a custom tray or special tray. Send it back to the dentist. The dentist take final impression, which this one is a good impression. You pour that impression, you make a master cast. This is the cast that you're gonna keep. Very good cast because it has good quality of impression. On this master cast, we create a record base or bite block, whatever you call it. Record base, bite block, wax rims. These are made of acrylic or sometimes made of just wax. These, the dentist will use them to record the relation between upper and lower jaw and measure all these lines like midline, canine line, smiling line, all these. And they add wax, remove wax, and see, and they ask if there's too much wax and they look the patient looks buffy, they remove the wax posteriorly, all these measurement, and they have to find the occlusion line and send it back to you as fused. And when they send it back to you, what are you going to do? Now you set up teeth. You remove some wax and you set up teeth. We call it setting of teeth. But you set up the teeth, but they keep them in wax and send it back. We call it a trial denture. It's a denture, but made of wax. Why? Why made of wax? Because we're going to send it back to the dentist and the patient, and they try it in the patient mouth. You can see the patient will see their fit. They're good. The colors look good. They don't bite their cheek. They don't bite their tongue. They see the vertical dimension. So that's a trial denture. The teeth are in wax. So the dentist might arrange them, might remove some of them, may rotate them until the patient is okay with them. Approve the color, the shape, the size, location. If everything okay, the dentists make the patient sign. It's happened a lot. They sign it, and sometimes they take a picture of it, and they said, "Look, you agree about that. Everything okay?" Because when you send it back to you, you're gonna remove the wax and make it acrylic, and there's no coming back of that. While if they still in wax, we can change them. And you're going to charge the dentist anyway about that. The dental lab technician going to charge the dentist after that. So if everything okay, the patient approve it and the dentist approve, they send it back to you, the trial denture with teeth. And what are you going to do now? There's a process called flasking. You know what's a flasking? We remove the wax and we add acrylic, hot cure acrylic, and you create a denture with create the whole denture. And we finish
the device that you use for flasking, but I've never
the flask.
done
We
it.
have. I'll show you the videos and the lecture. We go through that. The flasking. Flasking is very important, and is nowadays there's many ways. There's injection flasking. You inject them. Before that, there's packing. You can pack you mix them and you put it in the flask and you compress it. But now the injection is much better and easier. Anyway, so we reach that. We finish it, we polish it, and send it back to the dentist. The dentist, what do you do? You try it. We call it insertion, and if the patient is okay, and he might send it back to you for adjustment. Maybe there's a high spot. These are the steps of complete denture.
But sometimes do the dentists try to fix some of those issues if he can on his end before he goes
Yeah,
to
you
that?
can do that. Yeah, they can do some of that, but the whole process, the dental lab technician is very important about that. Like 90%. A part of vertical and horizontal dimension, most of the job works done by the dental lab technician because you create the cost, both of them, the steady cost and the master cost. You create the record base. You create the the trial denture, the denture teeth with wax, and you create the regular flasking and packing and curing of the acrylic, and the dentist would just insert insert the denture of the patient.
I'm just curious, how long does the dental lab keep the master cast of patients? Like, is there a shelf life of how long they keep them?
At least 5 years, because 5 years, because after 5 years they change, the tissue will change. If you don't have denture, or if you have denture, the tissue will resolve and there's a change. But nowadays, where the digital dentist, you can scan it. You scan the cost and save it as a file. STL file is one of these files. So whenever the patient asks you, you can just 3D printed that cast, because there's a limitation of space. And it's very important because I have one of my friend, she had it's not complete denture, but she got bridge, and the bridge is fractured, and he was looking for the cost to replace that, because usually if you have the bridge, the cost for that bridge, you can recreate that. So otherwise you have to remove the bridge, take compression, and let the patient without bridge or temporary until you create a new one. But now with the SDL file, with the scanning, you will have a digital copy, and that will be great. And most of the dental lab, they have quality control. There's like they have a senior dental lab technician do the quality control. They check the occlusion, they check the bite, they check the color, the shade. Most of the patient goes with B2 and D2. I'm D2, but because of the coffee and stain, I'm getting stained, so it will be D3. So most of the patients are D2 to 3. A1 is very rare. But nowadays, old people, they have A1 and they look ugly because they look too much white for their age. You know, when the patient get older, the teeth get darker or yellowish. You know why? Not only staining. Other enamel is mostly transparent, but with age, the dentin increase in size. The dentin is yellowish. So with age, the teeth gets yellowish. And a part of the stain, there's internal staining and external staining. That's another cause. So there's fabrication process, receive the dentist prescription, pouring models, creating custom trays. You do articulation, wax set, processing, finishing, quality control. These are. There's always challenges. Complete denture. Complete denture challenging is the lower denture because we don't have space, and we don't the good bone that we have good denture, good support. And most people, they come with us, they don't have enough bone. So that's anatomical variation. Sometimes that we have extra bone. Some people, they have extra bone in the palate. We call it tori. In the upper and the lower, we call it mandibular tori. It will be in the lingual side of the premolar area. Material handling. Acrylic, sometimes irritant. We work with if you work with acrylic before, acrylic will irritate your fingers. So try to be careful with the acrylic. But it's not toxic, but it just irritates yours. Aesthetic expectation. Nowadays with the Hollywood smile and stuff, some people, they will ask for like fancy. But the problem is complete denture will never replace natural teeth. Even with implant and stuff, will never replace it. There's a if you have the food will stuck between your upper molars, you know where's the food, so you could remove it. So I just got email from Marsha. She said she's working. Maybe we can change it for we'll change the time for 1 o'clock, because Marsha and Cody, they sent me an email, they are working at this time. So maybe we can do it at 12 or 1 o'clock.
Just on Wednesdays?
No, I will see you next week individually so we can talk about it, so we can arrange the date, because Ari and Marsha, their work, they are Cody, they are working. But Brooke and Bailey, they work with their family, so they can arrange for that. But I don't know. So we can agree on the what time will be the lectures. Anyway, what am I talking about? I was talking about something.
The way they want it to look, but they're never going to replace.
Yeah. So there's in the periodontal ligament, there's a special sensation called proprioceptive. So if there's food between the two molars on the back, immediately you know where's that food. But in complete denture, they lose that proprioceptive reaction. So when I bite, oh, I have teeth, I will take care of the bite. I'm not going to break my the force. is not going to be very strong. The problem with the if you have a complete denture, you lose that sensation. So the bite will be crazy, very strong. And one of the main failure of implant supported denture is the fracture of the implant because of too much pressure. The patient doesn't know how much pressure because they don't have that sensation proprioceptive. And nowadays, like one of the treatment, even if you have roots in the arch, just keep them, make the root canal on them, and cover them with a small crown, just to keep for two reasons. One reason, they keep the bone alive because there's a support for the bone. The bone will be there's a root, the bone will stay there, and also because of the sensation proprioceptive. So it will be not too much pressure. That's communication with the dentist. It's very important, the communication with the dentist. Your dental lab technician, especially if you have your own lab, you need customers, and you have to whenever the dentist call you, you send them. Usually they have FedEx. They have FedEx labels. Whenever they have a case, they put the FedEx label and send it to you. But you need the customer. You always good be respectful. Sometimes the dental lab technician have more knowledge than the dentist, especially neurograduate dentists, but they shouldn't show it. They just have to be good teacher and communication with the dentist is very important. That's created denture, both science and art, attention details, patient satisfaction, skill restored. Yeah, the thing with the with complete denture, it's experience. And the first denture is gonna be not perfect. The second will be okay, but with time you will know where's the problem. One of these lectures I learned from some of the teachers of courses. When you make denture, a complete denture, I use just one molar in the back, not two molars. But you have to convince the patient one molar because, in the lower, after the first molar, the mandible will go up because we call it retromolar bad. And that's will reduce the stability, reduce the retention because so if you make one molar in the back and one molar on the top, will reduce the the instability. We will have more retention, more stability. But you have to convince the patient he don't need that molar. In natural teeth, when we have natural teeth, more of the chewing will be on the molar. On complete denture, most of the chewing will be in the premolar area. Most of the chewing, and when in a human natural teeth, when we chew on one side, the other side doesn't touch, because the complete denture acts in one unit. If you chew on one side, the other side has to be balanced. So we call it working side and balancing side. When we set up teeth, there's one lecture about that with the working side and balancing side. It's very important when you set up teeth. That's a conclusion. Complete denture essential, sort of. Okay. I think we discussed all these things precise, very important. What do you think? Did you get more information about the denture? Did you learn something?
Yeah.
Yes. So yeah, complete denture is very important for dental lab technician. They will learn a lot, and there's very important. And if you don't know complete denture, and if you when you start working in the dental lab, the first thing they will make you work on removable. Removable is the basic, and the most common removable is complete denture. So you have to be very good in complete denture, and then you more specialized. You will do chrome cobalt partial denture, and then you start doing crowns, and then you're gonna be you do implant, and the most common people they make the most money. They call it ceramics. They build ceramic. Although nowadays with the 3D printing and digital dentistry, most people they make money on the digital, and if you if you master that, You can work from home. You have very fast computer. You have the software. The dentist email you the impression. You design it, and you make the teeth, and you choose the the color, the shape, the shade, the size, and send it to the 3D printer company, and that the company 3D printed and email it to the dentist. Yeah, that's the future of uh, the future of dentistry. But till now, digital dentistry did not replace the traditional dentistry. And nowadays, because I've seen many crowns, if you do it traditionally, much better than digital. Although the digital is growing and getting better, but they push it. The companies, they try to push the software because they're going to charge you. You cannot use the software unless you have to charge it. Every year you have to pay for the renewal, updating, and the library of teeth. You cannot use any teeth. You have to buy the library of teeth, and so digital dentist. You have to learn the traditional dentistry before you jump to digital dentistry. Okay. Do you have any question?
I just have a question about like these quick dental dentures in a day places. I've just always
Yes.
wondered this because my dad actually got one from them and he had a lot of teeth extracted and they did not wait until he was completely healed before they did the first impression. And I was always wondering why because his dentures have never fit him.
It's money. Most of the denture in a day, they have a dental lab technician with them. The problem is when you extract the teeth, what they do, they take impression before extraction of teeth, and the dental lab technician on the cast remove the teeth on the cast before the patient extract their teeth. So how much the dental lab technician have experience, they will never know how much the bone gonna shrink.
Mm.
Not gonna be 100%. So almost always when you do immediate denture, you need the relining. Within at least 2 months, 3 months, you do relining. And within 1 year, you have to do rebasing, and the whole base can be
Yeah, so he
removed.
had no idea. No one told him to go back or anything. It just never fit him right.
You do relining. Okay, there's soft reliner, I think from Amazon. You can order soft reliner will be paste. You put it there and they wear it. It will set within a few hours, and it will fill the gap because every time you extract the tooth, the bone shrinks, gets smaller, so the denture looks bigger on it. And even natural, if you extract teeth, even with age, the bone gets smaller and smaller because they have no teeth.
Mm.
So there's always need a relining. And I know the cost of the implant. Implant is much better, but it's very expensive unless you have. Now the insurance company will pay 50% for the implant, but still very expensive because the complete denture you need at least 4 on the lower, 4 on the upper, and I'll talk about all in 4 and a lot of complication of it. Yeah. So
Interesting.
yes. All right. Any other question? Okay. If you think of any question, you can email me, and I'll hopefully it's recorded, so I will send it the lecture. I'll send it to the other student. And thank you for coming, and welcome to the dental lab world. Okay.
Thank you. Have a good day.
All right. Thank you. Bye.